Hey everyone. We are going to go ahead and get started. My name is Indy, and I am a co-president of the Neuropsych Club, and we are very happy to collaborate with the Biomedical Sciences Seminar to bring Dr. Alison Heru here today. So Dr. Alison Heru received her medical degree from the University of Glasgow in Scotland. After graduating, she went to the University of West Indies in Kingston, Jamaica. She returned to Scotland and immigrated to the US. She did psychiatric training in all 3 countries and is currently a professor of psychiatry at the University of Colorado, Denver, where she specializes in the care of patients who have medical and psychiatric illnesses.
She's the Vice President of the Clinical Services and Initiatives in the Department of Psychiatry. She's published extensively on family therapy and the integration of psychiatry into medical specialties. The talk today is going to focus on the interface between psychiatry and neurology, specifically on patients with non-epileptic seizures. So let's please give a warm welcome to Dr. Alison Heru.
Thank you both. I need to get a mic check and make sure that you're hearing me okay? Okay. So thank you all for coming, and welcome to 2020. I wanted to start by giving you a little bit of an understanding of my journey to this point. As you can tell, I've practiced in several different countries, and when I graduated from medical school, my first thought was, what am I going to do? What am I interested in? And I did internal medicine for a while. That's when I went to Jamaica. I did internal medicine there. I did it in Scotland and then in Jamaica. And I found that the patients that were most interesting to me were patients that also had medical illness. So I was in the emergency department in Kingston, Jamaica, and I was there with my medical student. I was a resident. I was like 2 years out of medical school. And a patient was referred to me because she was speaking gibberish. And I went to see her, and I said, this patient does not have a psychiatric illness. This patient has a neurological illness. And I said to my medical student, I said, if I'm wrong about this, I will tear up my medical degree and go home. So it turned out that the patient had blocked a carotid artery and had expressive aphasia and dysphagia, and her gibberish was related to a neurological disorder, not to a psychiatric disorder. So it's experiences like that that help you decide where you want to go in medicine. Then I went to work at Butler Hospital, where I worked in Providence for many, many years, and I found on an inpatient psychiatry unit, the patients that were most interesting to me were patients that had medical illnesses. And so I would sort through these psychiatric patients and figure out which ones may have medical illnesses that were affecting their psyche. And that sort of discovery, detective work, I found was truly fascinating. I went to Denver about 12 years ago because I was really bored with working with inpatient psychiatry patients. It was becoming too much of a routine. So I went to Denver about 12 years ago, and I developed relationships with the people in the neurology department, and specifically one woman, Dr. Laura Strom. And she and I would talk about the interface between psychiatry and neurology. She was a neurologist. She was an epileptologist. She'd always wanted to do psychiatry. So the two of us would, and I sort of had a bent towards neurology, so the two of us would have interesting discussions. I would put forward these theories about the brain, and she would say, that doesn't make any sense. And she would put forward theories about psychiatry, and I'd say, that makes no sense at all. So between the two of us, we were able to work together, and it was she and I that decided we wanted to set up a clinic for non-epileptic seizure patients. This clinic has been very successful, and later this month, she and I are getting the University of Colorado Pioneer Award for having developed this clinic and provided these services to patients. So we're very pleased with that. So one of the reasons that I really like this population of patients with non-epileptic seizures is that when you think back to the beginning of psychiatry, the beginning of psychiatry was really in the early 1800s when people like Dorothea Dix decided that the mentally ill on the streets needed to be placed in an asylum and taken care of in an asylum. And the question was, well, who would take care of these patients? So the psychiatrists and the neurologists had a discussion about this because there weren't really any psychiatry and neurologists up to this point. There was a group of doctors who were interested in this illness, these illnesses. And the psychiatrists said, we'll take care of the patients in the asylum. You, the neurologist, you can go and treat patients in outpatient clinics. So that's the beginning of when psychiatry and neurology really became two different disciplines, because before then there were just doctors who took care of patients who had brain disorders and mental illness. So my goal for the future is that at some point in medicine, neurology and psychiatry will come back together. So it's been about 100 years they've been separate. Bring them back together and let's study the brain together, because every psychiatric illness has some relationship to psychological processes, et cetera, et cetera. So that's, I'm hoping when you're all my age, you'll be like, of course, let's bring these two things together. So I'm going to talk about the clinic, but before I talk about the clinic and how we set it up, I want to give you some words and phrases that you need to think about, and you don't need to remember, but I might refer to them. So let me ask, first of all, who knows what non-epileptic seizures are? Okay, so that's a good place to start. So why we decided to study these patients was because we have an epilepsy monitoring unit. Who's all familiar with epilepsy? Yes, yes, okay. So when you have an epilepsy monitoring unit in a hospital, 40% of the patients who come into the epilepsy monitoring unit do not have epilepsy. What do they have? They have something called non-epileptic seizures. And what non-epileptic seizures are when patients look like they're having a seizure, but when you put the video EEG on them and you capture them actually having the seizure, there's no electrical abnormality. So you know when you have epilepsy, that you diagnose epilepsy by showing that they have electrical abnormality in the brain. So these are patients who look like they're having seizures, but they're actually having non-epileptic seizures. Nothing is actually happening in the brain while they're having these seizures. So what do you think is going on? That was our thought. I don't know. We don't know what is going on with these patients. Why these patients who look like they're having seizures have no electrical abnormalities in their brain? So these patients have been somewhat stigmatized in neurology because the neurologists don't know anything about these patients. All they know is they don't have epilepsy and they can't help the patients. So the patients are told basically, you don't have epilepsy, goodbye. You don't have anything that we can treat, goodbye. What do you think that does to a patient who's having these kind of episodes? They get very upset, they get very distressed, they get very traumatized by the whole healthcare system. And you know, it may take many, many years before these patients actually get a real diagnosis of epilepsy. So they may be seen by neurologists, put on medications that actually they don't need because they have non-electrical seizures, and they're basically not treated correctly. So here's another medical student story. It's a medical student, this is in Colorado, and he's in the emergency room, and he witnesses this event. He witnesses a patient who came in having seizures, and then the emergency room doc puts on the EEG, it's normal, and the medical student is looking at this and watching what's his attending. The attending says to the patient, "There's nothing wrong with you. Your EEG is normal," and walks out of the room. So the medical student's now sitting with a patient who's highly distressed and sort of shaking the medical student, "What's wrong with me? I'm having something, and the doc tells me there's nothing wrong with me. There's something wrong with me," and then they have another seizure. And the medical student came to me because he was very distressed by this interaction, and he wanted to figure out how he could do his scholarly project on non-epileptic seizures. So he developed a questionnaire that we incorporated into our program, and he now is an integral part of our program. He went on to get accepted into our residency, and he's now one of our court experts on non-epileptic seizures. So this is my interest. This is an underserved population. There's no evidence in the literature about what the treatment should be for these patients. It takes me back to my roots in psychiatry, and it helps neurology because these are problem patients. There's a real, this is another reason to do this in a hospital, if you're in a hospital setting. There's a large financial burden and a significant harm to patients who have non-epileptic seizures. The costs prior to being properly diagnosed is $15,000, and that was in 2007. And that 75% of patients come to the ED, at least 6 visits, costing $3,000 or so per visit. They actually get admitted to the intensive care unit at the same rate as patients with epilepsy, and 40% of them are taking at least one anti-epileptic drug. So you see that this is a problem. You stumble on a clinical problem, and then you see that it's a problem for the patients, you see it's a problem for the neurologists, and then you see it's a problem for the healthcare system. So we're like, yes, we can actually bring all of this together and develop a clinical program. So this is a patient in the epilepsy monitoring unit.
Patient's just moaning a little bit. Can you tell me what you're feeling? I'm just going to cancel this a little bit. Can you tell me your name? Vicky. Can you tell me your full name? Haddock. Can you tell me what you're feeling? That sensation. The electrical one? Yeah? Yeah? Okay. Throughout your body? Throughout your body? Do you remember that phrase I said you remember when I first came in? No. Okay. No, okay. Okay, can you stick your tongue out for me? Can you try and stick your tongue out? No? Not right now? Okay. Can you tell me what's this? What is this? Can you open your eyes and look at what I'm holding? What is that? A pen? Good. You just have that electric feeling throughout your body? This is it. Okay. Are you feeling tingly? Yes. Yes? Okay. This is typical of your big events at home? Okay. How long does it usually last? That's all right. 24 hours? 24 hours?
Okay, so I know you couldn't hear much of that. The point is, this is what our epilepsy monitoring unit looks like, and this is what a typical patient looks like. They're connected to the video EEG, and they're in the other room. There are neurologists who are watching this, and they're watching the patient's movements, and they're watching the EEG. A lot of people who come to the epilepsy monitoring unit have behaviors that are difficult to discern. That's why they're there. And it's very important to differentiate between true epilepsy and non-epileptic seizures, because the treatment is completely different. You cannot make a mistake here. So the gold standard, this is a key take-home point, the gold standard is a video EEG is what you use to diagnose non-epileptic seizures. Yes? Go ahead.
So the EEG is on the head?
Yes.
So, I mean, I don't know anything about this, but is it possible that you could have a spinal cord or peripheral nervous system seizure that the EEG would not detect?
That would be a completely different, so that would be, you wouldn't be looking at an EEG. If it was spinal cord, you would be looking at peripheral electrical abnormality if it was related to peripheral muscles. Sorry, and spinal cord injury. These are all brain generated.
So if that was happening, you wouldn't detect it with an EEG?
If what was happening?
If there was, if the seizure was located in the periphery, then it wouldn't get diagnosed because...
So the seizures are all derived from the brain. So, I mean, if you have a tremor like this, that can be basal ganglia, and that could be a Parkinsonian tremor, and that would be indicative. The tremor would look like a Parkinsonian tremor. The patient would have other signs of Parkinson's disease. So if somebody has, some people can, as part of their epilepsy, can have all kinds of abnormal symptoms. They can have a type of epilepsy where you're laughing a lot or coughing a lot, and those can be picked up with the EEG. So it's very complicated, but the key thing is the electrical activity in the brain is correlated with the abnormal movements. That's how you diagnose epilepsy. And with patients with non-epileptic seizures, they have the abnormal movements but normal electrical activity in the brain.
Do they have normal electrical activity in the peripheral nervous system also?
I mean, probably not, because if they're shaking, the electrical activity in their limbs will be abnormal. But that's a very different type of process. So the patient is lying in the bed with the video EEG on. You can see that her movements are fairly subtle. You want to make sure that these are either epilepsy or non-epileptic. One of the things that patients with epilepsy, as you know, they're not going to be having epilepsy all the time, so there'll be periods of time where they don't have epilepsy. So one of the things that we often have to do is take them off their anti-epileptic drugs, or maybe stress them a little with a variety of techniques in order for them to have these events. So 40% of these patients have non-epileptic seizures, and before we started our program, the neurologist and the nurses would say, you don't have epilepsy, goodbye. And so that's where we came in to set up our program. The first thing that we wanted to work on was communication, because we felt that the patients were being traumatized by being told that they didn't have epilepsy. So this was the piece that the medical student got really involved in and really interested in. And this is kind of thing I would say to a patient. You have a seizure disorder that doesn't produce any electrical activity. We don't know what causes this, but it's likely pathways in the brain that are misfiring or there's bad wiring. What we do know is that we can treat you. We can retrain your brain, how to avoid the stresses that bring this on, and we can help you develop strategies to manage NES. We provide educational groups, medications, and therapy, and our program is 6 months long. So we started off with this as our first intervention. These are some of the quotes that the patients gave us after they started the groups. One of the things we asked everybody to do was to log how many seizures they're having, so that each day we could see whether or not they were getting better. This is the standard outcome measure for patients who have any type of seizures. At the end of the week, how many seizures did you have? That's how we measure if their medication's working or our interventions are working. So this one was quite good. Today I was a total mess running around trying to get things done. I took a mindful breath exercise, relaxed, and that helped so much. I finished everything, was able to get through the ceremony with no episodes. This is another one. I'm not even sure if my episodes are seizures anymore, if I'm stopping during the aura because they aren't full-blown. The feeling have changed, and my emotional status has been so great lately that I haven't been having nearly as many problems. So who gets this disorder? Here's the incidence. It's mostly women. And that brings a question, why is it mostly women? We're not sure. This is the age group, which is an interesting age group. This is the prevalence, and there are a lot of people who have epilepsy and non-epileptic seizures. So there's quite an overlap. This is one of the important slides. This shows you the comorbidity of psychiatric illness in these patients with non-epileptic seizures. So what we're doing in our clinic is that we're asking a lot of questions. Everybody gets a psychiatric evaluation. These are the diagnoses that patients have. And if you look at the bottom, you've got anxiety disorders. It's a really strong 90%. This is really important. So this is why psychiatrists are involved in managing non-epileptic seizure patients. What's also interesting is that now we've begun to figure out that a lot of these patients also have neurological disorders. The incidence of traumatic brain injury is high, the incidence of epilepsy is high, the incidence of chronic pain is high, and the incidence of migraines is high in these patients also. So these are patients who have got multiple comorbidities. So the question is, what causes all of this? Is there one thing that causes all of these, or is the non-epileptic seizure a consequence of a number of different disorders? It's an interesting question. Nobody knows the answer to that. So we're right at the beginning. This is why it's exciting to me. We're right at the beginning of trying to understand what non-epileptic seizures are and where they're coming from and what the correlates are and what some of the other associations are. Why is this important? We've got to treat these patients. So we decided to treat them. We put together a business case, which involved chart reviewing. It took us 2 years to plan the clinic. We put protocols for billing because we had to make sure that we could bill for these patients. We developed clinic flow. We developed outcome measures. We did a pilot study. We did trainees. We developed an educational video for patients. We gave every patient a video clip of that event that they had so that they could go home and show their relatives, this is what I have. And we trained the neurology staff, and we instituted a clinical research program. These are some of the metrics we used. I wouldn't be terribly interested from your perspective in what they are. There are too many. We have to keep cutting it down. We put the chronic pain scale in there because of the significant correlation. That was a recent addition. And we probably will start adding in more physical aspects. So this is what our clinic looks like. We do a psychiatric assessment. We do medication management. We do some family assessment work. We do a 5-week psychoeducational group. We do a multi-family psychoeducation group, which is, I often run those. That's with all the families of all the patients who come in, and they have lots of questions. And then we do a 12-week psychodynamic group, which the patients really like. We do a 3-month an initial 3-month and a 6-month appointment with a psychiatrist. I'm just getting over a cold, and I'm trying not to cough. That's that. So, where are we? I can talk extensively about any aspect of this. I've given you an overview of the clinic, an overview of some of our measures, and how we set the clinic up. So this is how I understand non-epileptic seizures. So this is my schema of the brain. I'm not a great artist, as you can see. The inferior frontal cortex is an inhibitory system. It's the limbic system in the brain, which is, you know, the brain has like 3 areas: the cortical, the limbic system, and then the brainstem areas. So it's the limbic system that's mostly concerned with non-epileptic seizures. There's been a great deal of research, and it really looks like it's the insula, the posterior cingulate cortex, and the orbitofrontal cortex, which are overly active, and the inferior frontal cortex, which is underactive. One concept I want to introduce to you is something called the default mode network. Has anyone heard of this? So the default mode network is, let me back up a little. So the brain is to me, the most interesting organ in the body because it's very hard to study and because there are many new techniques coming out over the past 10, 20 years. And looking at NES, we've gone through, is there a problem in this area of the brain, structural lesion? Is there a problem in the white matter tracts? Is there a problem in the connectivity in the brain? And one of the most recent interesting pieces of this to me is that recent researchers have started to talk about attentional systems in the brain and then the default mode network in the brain. And the default mode network is one you're all very familiar with these 2 different states. Your attentional networks are when you're reading and you're studying. When your mind is wandering in class or out of class, that's your default mode network that's engaged. So the question is, do some of these unexplained psychiatric illnesses or psychoneurological or neuropsychiatric illnesses, are they related to abnormalities in this default mode network? And we don't know the answer to that. But it's clear that brain research is just beginning to help us try to understand some of these issues. So I've thrown a lot of information at you in all different areas. I've got lots of things I could talk in more detail about. If you have questions, maybe we can engage in a discussion. Yeah.
It's all very fascinating, especially default mode network and limbic system. So have you been able to start to, when you look at this group of patients as a whole, to break down, do some of them look the same as others, or is everybody so different that you just have to approach individually?
Yeah, we've treated 400 patients through our clinic, which if you look at the literature is the biggest number of patients that have been treated through a particular clinic. Everybody is different. We have a collection of veterans who have had both post-traumatic stress disorders related to war. They also may have had TBI, so that's a very separate group. They're very different from the younger women who may have had a lot of childhood abuse, sexual abuse, physical abuse, and who have many different psychiatric illnesses. You have, I'm sort of running through some of the patients I've seen. One woman was a teacher, and she had to go on stage and do presentations. And it was hard for her because she had these non-epileptic seizures. I think one of the things that has been interesting to me about the patients is there are some patients who really want to get better and will really work hard with us on our program. And then there are other patients who are quite happy to be disabled and to be taken care of. So we're trying to differentiate those. What we have found so far is that there's no difference in outcome between patients who are trying to get disability and patients who are not. So that was one of our first cuts. Is this a motivating factor? Because some patients engage and some patients don't engage, but that was not found to be the case. Yes?
What screens did you use for, I guess, things like malingering? And also, you talking about the attentional system, were you seeing that like, I guess, the patient's attentional state during a non-epileptic seizure, did you see that had an effect on the presentation of the non-epileptic seizure, whether they were trying to focus on something at the time of the seizure or not?
So the question of malingering is important because that would be what the neurologists would often say to the rest of the staff. Don't pay any attention to that patient. They're malingering. They don't really have an illness. And we've not found that there are any malingerers in this population. And a lot of neurologists had tests that they would raise somebody's hand, and if it hit them on the face, then they were malingering. All of that stuff has really gone out the window, and nobody considers this population to have malingering in any way at all. Because the patients and the physicians would get into a battle, because the physician would say there's nothing wrong with you, the patient would say there is something wrong with me. A lot of poor communication and difficult interaction happens. And when that happens in a hospital, a default can often be to say the patient's malingering because they don't have a real illness. And one of our missions is to show this is a real illness, these are really sick patients, and there is a treatment for them. The second piece was about attention. So there are part of epilepsy and non-epileptic seizures is that there's an attentional component to this because the patients are not really aware of what they're doing or what's happening. Try not to cough. So that's a piece of it. Is that what you were meaning in terms of attention, or they were doing it intentionally?
I guess specifically I was thinking along the lines of in people with things like tics or I'm trying to make tremors, that some kinds are like repressible with concerted effort versus other things are, no matter how much you're focusing or trying to repress a movement, you can't. And are you seeing any pattern like that in these patients, that like it only manifests when they're not paying attention to it, or is it not really like that at all?
So part of the psychoeducational group is to teach patients, or let me put it another way, is to help patients understand what triggers there are to these events. And once patients understand what the triggers are, then they can step back from that trigger. They can either avoid the trigger, or they can manage the trigger better. So that's what we teach them, is how to recognize when they might have these events and to be able to manage those better. You saw the quote from the person who did that mindfulness breathing. She was aware that she was about to have one of these events and was able to abort it. So we give the patients a sense of mastery over their symptoms and also techniques to manage those symptoms.
Okay, sorry, just one last thing about the attention. So the attention is coming in more in a management aspect rather than in the origin of the non-epileptic seizures.
Exactly. Was that at the back? Yeah. I don't know of those because the people that are studying this are neurologists and psychiatrists. So if we could recruit somebody with that background onto our team, we could answer some of those questions. But this is a fairly new area. And so currently what we're trying to do is recruit some imaging people, because I would like to image this lady, give her a functional MRI before and after. So that's one of our focus right now, is trying to do more imaging with these patients.
I was just wondering about treatment modalities and if you are using anti-epileptic medication at all, and also once people kind of go into remission, if you're finding that their psychiatric conditions also are letting up at all?
So because these are non-electrical and these are not epilepsy, our first goal is to get them off all anti-epileptic medication. So that's our goal, our first goal. Everybody's seen by psychiatrists, so all of these anxiety disorders, PTSD, depression, etc., they're all treated. So we treat them, and that's part of our treatment. We also provide psychotherapy for them so that they learn to manage some of these events themselves.
Do non-epileptic seizures tend to mimic a specific subtype of epileptic seizure, or do you observe a similar range of features such as like absence versus tonic-clonic, et cetera?
Good question. So Dr. Strom and I did a grand rounds at neurology grand rounds, and we showed half a dozen of these, and we asked the audience to vote on which ones they thought were epilepsy and which ones they thought were non-epileptic. Everybody got it wrong all the time. So the answer is no, you can't, there's no particular subtypes, and you have to do the video EEG. That's the gold standard. That's the only way you can tell. People have tried to think about how they might do some of it without doing the video EEG, but none of it's, don't even think about anything else other than the video EEG.
So if somebody's having a non-epileptic seizure, typically you will see sort of a variety of presentations?
Yes.
Similar to epilepsy?
Right. And that's why so many of them end up in the ICU, because they look like they're having grand mal clonic-tonic seizures, so people intubate them. What we tell patients is wear a wristband which gives instructions about what to do if you're found, because a lot of these patients are taken by EMT, they're given all kinds of drugs, rushed to the hospital, put in the intensive care unit. So the woman I was talking about on the stage, the teacher, she had a whole written thing that she carried with her. It would be, I am having non-epileptic seizures, do not call 911. Call my husband, he'll come take me home. Put me in a safe, quiet place and I'll be fine. So everybody in her school knew that that's how to manage her seizures. So that's the biggest complaint, is that most of the medical profession doesn't really understand, or EMTs understand what this is. We did a presentation to our emergency department recently, and they were amazed that we knew so much about this disorder, because they had just been doing the, you don't have epilepsy, goodbye. So we're changing the culture within the emergency department also. Other questions?
So to be flippant, the brain is just a vessel for controlling the most important part, which is your peripheral nervous system, right? Who cares about the brain? So how often do you do, I wouldn't even know what to call it, but I guess you would call it a peripheral workup. Is that something that you would do all the time on these? How often do they have peripheral neuropathies? I'm wondering about autonomic disorders as well, and how often if a lot of the patients did have disorders of the peripheral nervous system, do you think they would get under the radar given the standard tests that you do?
Well, we don't see any of those patients, but just to develop that idea further, a lot of our patients, because they have non-epileptic seizures, will sometimes have difficulty walking. Some of these patients have difficulty walking, so we use PTs, physical therapists, a lot in the management of some of these patients. Yes?
One of the patient statements mentioned an aura. Are auras common in these patients, and what types of auras do they have? And are there other sensory disturbances?
She was using aura in the sense that she could tell that something was about to happen, not in the traditional sense of an epileptic patient who has an aura where they see lights or so forth. She just could tell, and a lot of these patients they develop an understanding of when they're going to have a non-epileptic seizure, and they would call that an aura, or because they've often been diagnosed with epilepsy, and so they're used to that lingo. And it's usually 7 to 10 years that they've been treated as somebody with with epilepsy, and they get asked all the time, "Do you have an aura?" And so that lingo becomes part of their way of thinking about their illness. Yes.
I want to really thank you for speaking to us today. I think your work is really fascinating, and I'm thinking about way at the beginning you mentioned, sounded like you were hopeful that over time neurology and psychiatry would collaborate more, and it almost sounded like you were inviting us as students to be part of that. And I'm wondering what you think would help or what is needed to bring about that kind of future.
Two things. There are places in the country that have neurology and psychiatry combined fellowships. There's one at Brown. Kurt LaFrance runs one at Brown, and there are several others in the country. A lot of the psychiatric programs are now developing neuroscience curricula that go across the psychiatric training. So psychiatry is moving. If you look in the American Journal of Psychiatry, it's all neuroanatomical and brain science. So psychiatry is moving in that direction, and neurology is all because if you're a neurologist and you're in the clinic, the most common thing you get is somebody with a headache. The second most common thing you get is somebody who has a functional neurological disorder, which means neurologists don't have any current way of identifying what's wrong with that patient. That's the second most common presentation to a neurologist. So they need us, and we need them. So the combined residency training and also a combined awareness in both of those residency programs that this is a field that needs to go forward. We have in our department MRI research division, and pulling some of our psychiatric patients through those into that research, so clinical research focusing on trying to identify either neuroanatomical or functional brain or dysfunctional brain activity is kind of clinically where it's at. Yes?
you able to, in like the programming for the patients, they're treated for their comorbidity as well as the non-epileptic seizures? Are you able to differentiate the results that you get? Like, for example, if they have anxiety, they're being treated for anxiety and their non-epileptic seizure. Is the anxiety treatment helping that, or is the non-epileptic seizure treatment helping?
It's a great question. We don't know. And that's part of the problem, I think. When we designed this, we thought, what are we going to, how are we going to do this? So we decided we'd just we decided we'd do a group-based program. And we decided we'd do a group-based program based on two things. One is that psychoeducation for patients is a very good evidence base for the treatment of any illness, whether it's diabetes, whether it's depression. If you put people in a group treatment, those are much more likely. Psychoeducational group treatment, not just any old group treatment, but psychoeducation. And psychoeducation means that you educate them about your illness. The psycho piece of that is that you talk about the emotions related to that diagnosis and how to manage that diagnosis. Those types of interventions work for many chronic illnesses. So we decided to start with that. And then, so we kind of went from what do we know as clinicians work for patients, and we knew that that worked for patients. So we didn't start off with what our hypothesis was about what was causing these illnesses, because as you can see, we don't know, and there are all these different things going on. So we thought, let's just pick what we know will work. It's the psychoeducational piece. What will the hospital pay for? How can we trained up nurses, nurse practitioners, psychiatric residents, neurology residents to run these groups. So they're running at this point every 6 weeks autonomously within the Department of Neurology, and the patients do extremely well. These are the things that they fill out at the beginning and they fill out at the end. We're looking at the seizure diaries to see that they're getting better. We also look at their GAD-7, which is the anxiety scale. The COPE, which is interesting, it looks at their coping mechanisms, et cetera, et cetera. So we're looking at all of these, and we haven't actually run the stats on all of these at this point. We've just looked at their seizure diaries, but we don't know what's helping, but we just know from clinical research that psychoeducation helps. And so we started there with a model that we could fund, and we had the personnel. A lot of the problems with, if you're doing clinical research, is that people set up these programs that are not sustainable. And so you have a great result, but then you leave, and the whole thing collapses. So this was important to have something that was built into the fabric of the clinic and that could be done by people easily. Good question. As I was saying that, I was like, well, I get a question about that. I haven't actually looked at that, but psychoeducation will help patients with epilepsy manage their epilepsy. They'll help them understand the side effects of their medication. So I don't know if there's anything being done in that area, but I would imagine it will help patients in terms of managing and understanding their illness. And excuse me, the medications that are used for epilepsy are often very difficult to tolerate. So helping patients understand what's the side effect, what alternative medications. Dealing with any chronic illness like epilepsy or diabetes can be can wear you down. It can lead to a lot of demoralization. So some of this psychoeducational stuff is focused on on that, especially with the family psychoeducation group. It really helps families understand and help know what their role is and how they can be helpful.
So one thing that is kind of interesting to me is that the epileptic seizure, like you're seeing a big EEG on, and you can see that there's abnormal electrical activity or firing patterns happening in the brain that's, correct me if I'm wrong, kind of what's causing the seizure. But in a non-epileptic seizure, you can't see abnormal brain activity, but it seems that the non-epileptic seizures are being helped by psychoeducation. People are able to use things like mindfulness to actually decrease the incidence. So I'm wondering if epileptic seizures behave similarly, where people can actually control going with that, or if there might be a different.
Yeah, I mean, there's work being done in epilepsy on patients being able to control some of their seizures. Again, it depends on the severity. Some of the patients that come into the epilepsy monitoring unit have very severe abnormalities in the brain, and they actually go on to have surgery and cut out that part of their temporal lobe or whatever that's causing these seizures that are not managed by medication. But if somebody has a milder epilepsy, there are some studies which show that patients can learn to manage some of that in conjunction with medications.
Okay, how do you know the brain is involved?
What else would be involved?
Yeah, I'm sorry. Or the spinal cord, maybe it's spinal cord. You could have seizures within the spinal cord, maybe, or autonomic reflexes that are becoming uncontrolled. Other parts of the nervous system could be. Well, if it's not in the brain, then it would have to be somewhere else in the nervous system, I guess. Are you okay?
Yeah.
So I've thought about this a lot in my epilepsy research career, and it's kind of, Ben keeps bringing this up, so I thought I'd throw this out. When we're recording EEGs from patients who have epilepsy, we're solely recording EEG from the cortex. There's a lot of brain tissue underneath the cortex that we have no idea what's going on. And I know work that we've done and other people have done in animal models show that there is actually ictal activity below the cortical level. In things like blasphemous, I'll say this, the hypothalamus. And so I wonder, I know the answer is probably no, because you don't know the answer to this, but I wonder, have you ever thought about local pockets of ictal activity maybe being in these non-touchable areas by EEG, that they really do have seizures, but you just can't see it because you're using this very gross EEG methodology?
I think about that a lot, but my neurology colleagues don't think about that.
Neurologists don't want to hear that.
Right. So that's part of the interest in this disorder, is that if somebody develops more sophisticated techniques for examining lower levels of the brain and maybe looking at the default mode network or something else, we will find something.
Yeah, and if you actually look at so I have a friend of mine who does work in this, his name's Hal Blumenfeld, he's at Yale. He's actually done fMRI recordings of individuals while they're seizing in a magnet, and he can actually show a lot of activation going on in subcortical regions, which the only way you'd see it is if you stuck depth electrodes into these patients' brains, which you're probably not going to do. So it's becoming very clear that other parts of the brain besides the cortex can show ictal activity.
Yep. Yes.
Yeah, traditional neurology teaching says that the cortex is the only portion of the brain that can seize because of the way it's constructed. You need those long dendritic expanses to do this. However, when you look at things like chronic pain, you look in the spinal cord, the pattern that chronic pain takes is one of kindling and getting progressively progressively worse. The ictal periods get longer, the interictal periods get shorter, and in many cases, the chronic pain patterns will respond to anticonvulsants. So there's, although it does not reach the level that it's probably recordable as a through an EEG, it's doing the same thing. It's high frequency, rapid neural discharges. And could it happen in other places in the brain outside of the cortex? Quite definitely. I would actually look and see if you could get a pattern whether these actually kindle and whether you can record the length of time between them and see if that's shortening. That would lead you down that road of saying that this actually is probably some high neuronal discharges that are damaging the inhibitory system that then could be approached like that.
Thank you. Okay, I think we're done with that.